Good afternoon, good evening, everybody. My name is Christina Lampe. I'm working at the University Hospital of Gießen in Germany, and I'm very honored to speak in a row of very famous lysosomal persons like Paul Hamas, Maurizio Scarpa, and Roberto Giuliani. And I would like to present today MPS case studies, practical examples of an effective identification and referral process. And I hope you forgive me that I have a lot of slides, and I kindly ask you not to take any screenshots, not to produce any of the slides, and please submit your question at any point via the question panel, and I will answer the question at the end of the webinar. So if you want to see the presentation again or the others, they will be also online available on mps.spot-early-science.org. So here are my financial disclosures. Paul Hamas gave already a very nice introduction to the MPSs, and I just want to remind you again that we are talking about 7 types of mucopolysaccharidoses caused by 11 enzyme deficiencies. And to make it a little bit easier to speak about cases and also diagnosis, I usually group them a little bit in MPS 1, 2, 6, and 7 that are showing mainly joint stiffness, and I call them the stiff ones. In contrast to that, we have MPS 4A and B, which have more musculoskeletal symptoms than the other types, but they have hypermobile joints, so a little bit different. And MPS 3, I will not focus on that today, which has not that much somatic signs and symptoms of the disease, but more a cognitive involvement. We all know that MPSs are multisystemic diseases with signs and symptoms of almost all organ systems, with a very high variability on heterogeneities in symptoms and organ involvement. We have cognitive involvement in all MPSs beside MPS 4 and MPS 6, actually. And just to give you a very brief overview, we have the MPS 4, the hypermobile ones that have classical cases, but also with a wide variability of signs and symptoms, non-classical cases with more subtle disease complications. We have MPS 6 from very severe to attenuated, and this is for all MPSs the same. Important to know is that with the wide spectrum of disease severity, the disease can also be very specific in some organs in patients, but not all organs are affected. So the disease itself is very specific or individual for each patient. What we know is that they have all a storage of glycosaminoglycans. We know they can be slowly progressive, they can fast progressive, but nevertheless, it is a severe disease and not a mild disease at all. To show why it is so important to diagnose patients as soon as possible is that we have enzyme replacement therapies for many MPSs, and you see here the table of all MPS types, and in red and bold, the ones where treatment is available. And actually it is beside MPS 3, for 4B and 9, we have treatment for almost all MPSs. And since we are talking about progressive diseases, it is extremely important to diagnose and start treatment as soon as possible in that patients. And actually many promising clinical trials are ongoing also for MPS 3. So this is why it is extremely helpful and beneficial for the patient to diagnose early. The diagnostics Paul mentioned already is the screening with the glycosaminoglycan excretion in urine. We have this gold standard, it's the enzyme activity measurement in blood, but also dry blood spot tests are available for the treatable MPS types, and the genetic testing. We have the enzyme replacement therapy for many MPS types, as I have shown in the last slide, but we have also a hematopoietic stem cell transplantation in MPS I Hurler patients if they are under the age of 2.5 years. And this is why it is so important, because with this treatment we can stop the cognitive decline in MPS I patients. So the earlier you perform the transplantation, the better it is. So now coming to case reports and the earliest signs and symptoms, and I will start with the stiff one, so MPS 1, 2, 6, and 7, but I will focus a little bit on MPS 2 because all these diseases, the stiff ones, are quite similar in presenting early signs and symptoms. Here you see 4 boys between 2 and 3 years of age, and if you look at them, in a way they look similar, although they have different faces. And I go fastly through these cases, but if you see the pictures, you cannot see that this patient is suffering recurrent infections of the upper airways and ears, but you see a kind of stiffness of that patient. You see this enlarged abdomen, and you see the face that seems that he cannot breathe properly through the nose. The next patient here, recurrent infections of the upper airways as well, inguinal hernia on both sides, an abnormal gait, a kind of general stiffness of that patient, and a macrocephaly was found in that patient. The third case you see here, he as well was suffering of recurrent infections of the upper airways and the ears. He showed contractures of the fingers. He's the oldest one with 3 years in that group. He had inguinal hernia, a developmental delay, hepatomegaly, a general stiffness, and macrocephaly as well. And if we go to case 4, you see the boy here. You see as well the same story, recurrent infections of the airways and ears, inguinal hernia due to the infections, also in hearing loss, adenoidectomy was needed. He had a kind of developmental delay at the age of 2.5 years, was diagnosed as an hyperactivity, a macrocephaly that needed a shunt, and a general stiffness. And you see the big umbilical hernia and the enlarged abdomen. So this was very quick, but if you see these cases all together and the symptoms we saw, what we can see is that some symptoms are present in almost all these patients. And this is actually here, the recurrent infections were present in all these patients, the inguinal hernia, the skeletal stiffness, and also the macrocephaly. The inguinal hernia was not present in that case, it came later, but actually it shows that these are really the main earliest signs and symptoms in these patients. So the first conclusion is early signs and symptoms, recurrent airway and ear infections, hernia, inguinal or umbilical hernia, skeletal stiffness or general stiffness, and macrocephaly. These are all unspecific signs and symptoms, but the combination of these symptoms can really lead to a diagnosis. But as I said, it is unfortunately very unspecific, and this is also the reason why patients are diagnosed much later than they should. So here 44% show is the median age at symptom onset, but 1/3 or more than 1/3 of patients are diagnosed older than 10 years of age. And this is actually present for or true for all MPSs. We have in general in all MPS types a median delay to diagnosis of almost 3 years, and in 20% of cases a delay of more than 10 years. And you see here that MPS 2 is the median diagnostic delay is 4.5 years. In MPS 4, the hypermobile ones, 6.5 years. So it's quite a big gap between the first signs and symptoms and the diagnosis at the end. Another case here, and this is why it is so important to listen to parents. The mother noticed, since she had already 2 older daughters, a stiffness of shoulders at the age of 3 to 4 months in her son. And you see him here on the picture, and he cannot really move his arms in front of him. So he was never able to crawl, but he was suffering recurrent airway infections, He had several ENT surgeries. He had a language developmental delay diagnosed due to a hearing loss. And actually here, and you see him here on the picture, that he is in a way stiff as well. And he has contractures of the fingers. And an anesthesiologist recognized the contractures because he was not able to position him properly on in the operating theater, and he was suspecting storage disease. And this is why at the age of 4 years, even if he was already showing the first symptoms at the age of 3 to 4 months, he was diagnosed as an MPS 2 patient. You see here the progression of the disease. You see that he had also at 8 years an heart involvement. So it is a multisystemic disease, although in him the first sign was the stiffness of the joints. And you see here on the first picture with the green shirt, he wants to perform a peace sign with his fingers, and you see the severe contractions. And here also the contracture of the shoulder at the age of 12 years. So actually this is a typical non-neuronopathic case, so he has no cognitive involvement, but you see the long distance between the first symptoms, the diagnosis, then the long time of symptomatic treatment until he started ERT. He is actually on treatment since 2011. He is doing very well. I saw him yesterday, but still the irreversible organ damage cannot be returned to normal. And this is why it is so important to start early. Another MPS 2 case, and you see here, even if pregnancy and birth are normal in most cases, in some cases there's an hydrops fetalis present, but mainly the pregnancy and birth of MPS children in general is normal, and the children look extremely healthy at birth because they have normal height, they are even bigger than usual, they have a normal weight, and the first time of life, the first weeks and months are usually absolutely normal. And with the disease progression, and you see it here also in the child on the pictures, you have continuous symptoms that are added. So he had a mild developmental delay. Actually, he was also not crawling because of the contractures of the shoulders, and the parents were never able to hold him on his hands and walk with him because he was too stiff in his shoulders. He had inguinal hernia as well, recurrent infections, an enlarged head, and a hearing loss. And this is it is like repeating myself. These are different cases, but they have all the same actually history behind. This child actually, the parents were very concerned about his enlarged head at the age of 1.7 years, but they went to a pediatrician. The pediatrician said, no, everything is fine. There's nothing behind this enlarged head. This is just because he is like he is. At the age of 2.5 years, the parents insisted in visiting a child neurologist. He received an MRI of the brain, actually because of his hearing loss, and as a side diagnosis, there was found white matter lesions. He had, at this time, he was clumsy, he got tired quickly, he had this enlarged abdomen, enlarged head, and also the coarse face was really, the parents said, he's looking totally different from us. The mother was pregnant at that time, so this is why she was really insisting on having a diagnosis, and they tried to find, but the diagnosis was global developmental delay, in particular language developmental delay. But due to some lucky circumstances, they got in contact with a physician who knew about MPS, and this physician started a urinary gag measurement, then had the suspicion of Hunter syndrome or differential diagnosis alpha monocytosis, which looks very similar. They made an X-ray which showed scoliosis and a hip dysplasia and also cardiomegaly. And for this reason, at the age of 2.5 years, it was the diagnosis made of an Hunter syndrome. And this is a typical neuronopathic case. So here, these cases, usually the children are having kind of developmental delay maybe, but then they continue developing slow but normal. So as we saw in the first case. Now in this case, you see that with ages 3 years, he's losing fine motor skill, has a poor attention span, is very impulsive. With 4.5 years, he has a lot of loss of intellectual abilities and his mobility. With 5 years, he has a loss of interest in people, and the attention span is dropping down as well. With 5.5 years, he's incontinent, has an aggressive behavior, severe sleep problems, and a loss of cognitive skills. And this is very, very typical, not only for MPS 2, but also for MPS 1, that the development is a little bit slow, but then at a certain time, mainly preschool age, they drop down and they really lose abilities on cognitive abilities they had before. So what is my conclusion? The conclusion is the heterogeneity of the disease. Patients with MPS 1, 2, and 7 can present cognitive involvement, actually 70% of these patients. Patients with MPS 4 and 6 don't have any cognitive decline. And here's a case that I presented last year already, but I think it is a very good case because I have many pictures. And you see this child from Turkish parents with 2 healthy siblings after an uneventful pregnancy, normal height and weight at birth. And with 18 months, you see that she has dropped down from her percentile of height from 40 to 10%. She was suffering recurrent infection of the airways. She showed umbilical hernia, the thoracic kyphosis, which is always suspicion of MPS. Whenever you have a child with thoracolumbar kyphosis or so-called gibbous, you have to think to MPS and to exclude at least. She's also showing some pectus carinatum, here hip dysplasia, macrocephaly, and you see also a stenosis of the craniocervical cord. So she has no really joint stiffness at this time, but a general stiffness. So now is the question, if you heard all these symptoms already, so what kind of MPS is it? MPS 4 is more a hypermobile disease, so we can exclude MPS 4. She has quite a lot of somatic signs, skeletal signs and symptoms, so MPS 3 is unlikely as well. Why it is not MPS 2? I mean, she looks exactly like MPS 2. The reason is MPS 2 is X chromosomal inherited, while all the other MPSs are autosomal recessive. So, and she's a girl, so MPS 2 is unlikely as well. MPS 9 is so rare that I would like to exclude it here, but we have MPS 1, 7, and 6 that she could suffer from. So the diagnostic was done. The urinary gags showed only dermatan sulfate, while in MPS 1 we would expect dermatan sulfate and heparan sulfate, and in MPS 7 as well, also chondroitin sulfate. There was done an enzyme testing in blood, and there was shown an aryl sulfatase B deficiency in that patients. The genetic showed the mutation in the specific MPS 6 gene. And actually, why it is so important to make pressure in diagnosing these patients so early is that if it would have been an MPS 1 patient, and she could really be an MPS 1 from all the symptoms she showed, then we would perform immediately the hematopoietic stem cell transplantation, because if MPS 1 Hurler syndrome, so the severe type of MPS 1, we would expect a cognitive decline, and this we can stop with the stem cell transplantation, but only if you perform it up to the age of 2.5 years. So this is why it was so important to have a diagnosis as soon as possible. So it is an MPS 6 finally, but it could have been an MPS 1 as well. This is her at the age of 4.5 years. You see she is on treatment and she's better, but she has still some problems in walking. The girl has also a cousin that was born in 2018, and you see him here. He had actually quite a lot of difficulties during birth, which is uncommon for MPS, but you see him here that he started treatment in the first months of life, and you see him here at the age of 4 years, and he is absolutely less affected than the cousin who started much later. And here another case, what diagnosis would you find? This boy showed recurrent infections, umbilical hernia, enlarged abdomen, developmental delay. He was diagnosed as a patient with hyperactivity. He showed the macrocephaly and the skeletal stiffness that you can see here. And he had also these small pebbles on his legs and also shoulders. But nobody was thinking to MPS. Actually, he had also a coarse face, which is maybe difficult to see in him, but he had this, in contrast to the parents, this strange face, and actually he was diagnosed at the age of 5 years, even if the symptoms started in the first year of life. And this is actually a pity because it is quite late. But what I wanted to show with the MPS 6 and all the MPS 2 cases, the clinical differentiation between the subtypes, especially these stiff ones, is extremely difficult and can be a challenge. So it is always needed to perform enzyme activity in blood or dry blood spot and genetic testing for confirmation in order to start the correct treatment in these patients. And there's one case from the literature showing how important the early diagnosis and also the early start of treatment is. This is a child that was diagnosed with MPS 1 at the age of 4.4 years, and she started the enzyme replacement therapy at the age of 5 years, while her brother was diagnosed immediately. He's younger, so it was known that he is suffering from MPS, and he started ERT with 5 months of age. And she had quite a lot of signs and symptoms of MPS. And if you see here, the comparison, him after 5 years of treatment, at the age of 5 years, you see his hand skeleton looks almost normal, while in his sister, she was diagnosed at the age of 4.4 years and started treatment later. You see the skeleton of the hand that shows the typical dysostosis signs of MPS. And these are the two siblings at the age of 15 and 10 years, and you see these two and the sister that is much more or severely affected than the boy, even if they have the same mutation, the same parents, but the boy started 5 years earlier his treatment. So the conclusion 3 is early treatment. The earlier you diagnose and treat the patient, the better is the outcome. And this is why it is so important that you find and you diagnose these patients. Now, this was the part of the stiff ones, the stiff MPSs, now to the hypermobile ones, the MORQ A and B patients, but here I would like to focus on MORQ A. And you see here the disease severity. We have almost normal looking guys, but we have also patients with severe skeletal involvement. And this case actually was born in November 11 from after normal pregnancy, normal height and weight at birth. He was diagnosed very early at the age of 1.5 years. You remember the median delay of diagnosis in MORQ patient is 6.5 years, and he showed that time a kyphoscoliosis and recurrent infections of the airway. He had inguinal hernia repair, he had ENT surgeries, so very much similar to the other MPS types, but a hypermobility of his joints. So with 1.5 years, he was diagnosed. He started treatment at the age of 3 years because the ERT was not available until he was 3 years of age. And I just show you a small video of how he's behaving. You see the hypermobility of the joints, you see especially the hands in that case, and he's making some physiotherapy here at home. And you also see that he has even if he has this hypermobility of joints, he has contractures of his shoulders and the short neck. That is very typical. Here he is at the age of 3 years or 4 years, and what you can see is that the symptoms were progressive as well. He has craniocervical stenosis, very typical for MPS. You see the gibbous deformity of his back. You see the pectus carinatum. He has hip dysplasia, actually knock knees. And he lost his growth percentile because dwarfism is a typical sign of MPS in general as well, but that starts at the age of 3 to 4 years. So this is why you can miss it if you have a patient that is younger than that age. And he started the ERT at 3 years of age, and you see that he dropped down from the 50th percentile to the 3rd percentile of his height. And then after ERT, he started growing parallel to the 3rd percentile. So actually this is a very severe, a classical MPS 4A case. And in contrast to these very classical ones, the more attenuated cases like the non-classical MPS 4A cases have much more difficulties in being diagnosed. This child here was born at normal height and normal pregnancy as well. I repeat myself, this is typical for MPS. She has a younger sibling that is healthy, and she received the cognitive and motor milestones on time. At the age of 2 years, she had a strange uncertainty of running and tiredness, and the physicians recommended sports. She had recurrent infections of the airways and needed ENT surgeries as well. And at the age of 4 years, she had indeed a very suspicious gait, a wide-based gait with external rotation of the right knee, and all other examinations were normal. And I show you here how she's running. The child is this one with the white shirt and the red trousers. And you see here, I'm sorry for the noise, but you see her here coming in the video, how she's running, which looks very much strange. The parents were very concerned about this strange gait, and they tried to find some diagnosis. So they went from one hospital, one physician to the other in order to receive a diagnosis. There was performed at the age of 5 years a gait analysis, and you see her here walking, which is not a normal gait for a 5-year-old girl, but actually the diagnosis was clumsy child. And you see the longer she's walking, the more waddling the gait is, but in all other signs and symptoms are not present in that child. Actually, we have also some X-rays of her, and you see the typical radiological signs like the ovoid vertebrae in that child, but nobody was thinking to an MPS. She lost her growth percentile from the 50th to the 2nd percentile at the age of 8 years. You see here, now she was growing along her percentile, and then she was dropping down to the 3rd at a certain age. She had hip dysplasia. She was diagnosed as bilateral aseptic hip necrosis and an epiphyseal dysplasia. We saw the hand, but nobody was thinking to MPS. But at the age of 10 years, she was diagnosed with urinary gag excretion, enlarged gag excretion in urine, and also enzyme activity measurement as a MOCU patient, and so she started treatment. But between starting to walk at 1 year of age and 10 years, it's a 9 years delay. And the non-classical case here also with another MOCU patient, just to show you her pictures and the hypermobility of her joints, even if she does not look like a typical one. So the conclusion for is MPSs are not only metabolic diseases, but also skeletal dysplasias, and the typical signs, skeletal signs, are called dysostosis multiplex. So whenever you read that on a result of an radiologist, you should think to MPSs. Here are some skeletal dysplasias, and you see how similar they look like. For most of them, there's no treatment available, but for MPS it is, and this is why you have to really sort them out. And here in the red boxes, these are patients with an MPS. So how to narrow this gap? Actually, there's one publication that made a systematic literature review and included almost 200 papers out of 1,613, and an online physician survey asking 200 physicians in 16 countries about the first signs and symptoms that was triggering to screen for MPS. And for this, consider MPS tools were performed. And I would like to show you a few of these results here. And 859 MPS cases were described by the surveyed physicians. And what you can see is that more than 50% of MPS 6 patients showed a short stature, but also more than 1/3 of the patients. We have the skeletal abnormalities that were seen in 50% of almost all MPSs beside MPS 3 that has no real somatic signs, and MPS 7. So actually skeletal abnormalities and short stature are quite often, or any joint abnormalities are quite often symptoms. So MPS is indeed not only metabolic, but also a skeletal dysplasia. And in patients under the age of 4 years old, commonly presented with skeletal malformations, this is what we said, after the earliest signs and symptoms like hernia and recurrent infections, but also the dysmorphic features, the developmental delay, growth delay, psychomotor retardation were very, very common symptoms. And what survey and literature review is that the juvenile arthritis was the most common misdiagnosis for MPSs. So conclusion number 5 is more specific signs of MPS is the skeletal involvement, the dysmorphic features are very common, and the juvenile arthritis is a common misdiagnosis in MPS patients. And now at the end, I would like to make a test with you. I will present you a case, a boy at the age of 3.5 years, first child of German parents. Here is a younger sister that was born with macrocephaly. Everything was uneventful, pregnancy and birth. At the age of 3 months, he had hydrocele surgery. Developmental milestones were normal. With 18 months, he suffered from pneumonia. At the age of 3 years, he had a speech development and recurrent ear infections, and with 3.5 years, strabism and macrocephaly. In the X-ray of the skull, because he developed macrocephaly as well, he was born with the 92nd percentile. The sister, he was born with the 90 percentile head circumference, but now his head was growing, so they decided to make an X-ray and to find diagnosis, and they had the suspicion of a lysosomal disease. At the age of almost 4 years, you see him here, height and weight are absolutely normal, but the head circumference was 54 centimeters, so extremely big. And you see him here on the picture. He had also a coarse face, totally different looking from his family. He had claw hands. He had this square head with frontal bossing. You see in another picture better, pectus carinatum, in a way straight and stiff spine, an umbilical hernia with a weak abdominal wall, and hepatomegaly, and unclear speech, and a mild developmental delay. What do you think, and what would you do in this case? Actually, you do a routine lab, which is normal, ophthalmological. He has no specific signs, some astigmatism and hyperopia. ENT chronic middle ear infections on both sides, but hearing test was normal that time. He had in the skeletal assessments typical signs of dysostosis multiplex, an abdominal ultrasound with slightly enlarged spleen, heart, lung, EEG, MRI, everything normal. But in the skin biopsy, they found enlarged lysosomes. The developmental testing showed a mild developmental delay. So what do you do now? Diagnostics. You think to MPS, you have the typical signs, you measure the glycosaminoglycan excretion in urine. That was negative. This does not mean anything because you can also have MPSs, especially milder patients that have normal glycosaminoglycan excretions, and also in adulthood, you may have normal GAG excretion in urine. So you are not concerned about that, and you make an enzyme activity testing in blood. Actually, MPS 3B, probably not, because he has a lot of somatic signs and symptoms and not a severe cognitive involvement. MPS 4A, probably no, because he's more stiff. So you think maybe to MPS 1, 2, 6, and 7. But unfortunately, the enzyme activity test for these MPSs is negative as well. So would you do a genetic testing now? Or any idea, any differential diagnosis in that patient? Actually, there was an additional urine result that you did not read at the beginning because you were so convinced about MPS, but there were some oligosaccharides in urine that were increased. He looks like MPS, has the same early signs and symptoms of MPS like recurrent infections, hernia, developmental delay, macrocephaly. So all the signs and symptoms that you already learned that are typical for MPS. You have the same skeletal signs like MPS, so the dysostosis multiplex, and you have also a coarse face like MPS. So any idea what it could be? I help you. It is actually the enzyme activity in blood. There was found a deficiency of the alpha monosidase. So the diagnosis is alpha monosidosis. And there's also a dry blood spot testing available for alpha monosidosis, and there's an enzyme replacement therapy available for alpha monosidosis. And there's also the option of hematopoietic stem cell transplantation in some monosidosis patients. So this is him, just to give you an overview of his life. I know him since a few years. He's now 33 years of age, I guess, or 36. So at the beginning, in the first years of life, between 3 to 5 years, he was suffering recurrent infections. He needed hearing aids at the age of 5 years. At 14 years of age, he had several infections of the airways, enlarged head circumference, the coarse face, an ataxia, which is very typical and different from MPS, and a mild mental retardation. So actually, this is him. He's on treatment and he's very happy. And why do I show you an alpha monosidosis case in the mucopolysaccharidoses? Because in earlier times, when it was not clear that an enzyme deficiency is the reason for the MPSs, the alpha monosidosis was called Hurler-like syndrome, and Hurler is the severe form of MPS 1. So actually, it's very similar. It's a different disease, but it has a lot in common. So most important to, after you saw all these pictures, is MPS shows an overlap with common complaints of childhood, but the combination of these signs and symptoms may help to raise the suspicion of MPS or monosidosis, and you would test and you can start treatment early. There's a diagnostic tool developed that is very nice. So short stature or decreasing growth velocity, especially in the milder patients, recurrent ENT-related symptoms, infections, hernia or recurrent hernia repair, hepatosplenomegaly or developmental delay for some MPS besides MPS 4 and 6, and any additional features like cardiac valve disease, coarse face, corneal clouding. This peau d'orange that I showed you in one case, or skeletal involvement, then please think to MPS and test. It is easy, and you will help the patients quite a lot in not only having a name for the disease and avoiding jumping from one physician to the other, in order to find diagnosis, but also to start the treatment as soon as possible. And with this, I thank you for your attention. I know I was speaking quite longly and fast, but I hope you could see the pictures and you will diagnose patients very easily now. And now I'm open for questions. Let me check how I can open the chat. Let me check. Okay, so could strabismus be a sign of MPS? Could it be related to a specific MPS type? At which age? Actually, no. Strabism is not a typical sign of MPS, but if when some patients have an hydrocephalus, for sure the strabism can be due to that. So as I showed in one case, that hydrocephalus is present, and in some, especially in MPS 1 and MPS 2, there might be an hydrocephalus, but it is not a typical sign. The typical ophthalmological sign in MPS is the corneal clouding. Any further question? What's the very earliest symptoms that will alert me to investigate further? Actually, this is what I try to explain. A specific sign is whenever you have recurrent infection, hernia, macrocephaly, and a general stiffness. If a child, and the first 4 cases actually, I think, showed quite well that they have a very straight back and they look stiff in their movements. So whenever a child is not soft and flexible as you would expect from a child that age, you would start test for MPSs. And it is for sure, I mean, these are such rare diseases, you will not find hundreds, but if you have excluded it, at least the child has a chance to get a treatment if you diagnose. If not, you have excluded it, which is good as well. How can you avoid a misdiagnosis of hypothyroidism? Usually in most countries, hypothyroidism is part of the newborn screening, and for sure you can measure in the usual lab, routine lab, you can measure and then exclude hypothyroidism, which is probably much easier to exclude than an MPS, because you need the dry blood spot test, etc. The ERT crosses the hematopoietic crosses the hematopoietic barrier, avoiding the alteration in central nervous system. Actually, the ERT is not crossing the blood-brain barrier, the enzyme replacement therapy that we have approved now. But there are some clinical trials with enzyme replacement therapy in combination with an antibody that is linking to a receptor on the blood-brain barrier in order to cross. So there are some clinical trials available in Japan. There's one ERT that is able to cross the blood-brain barrier already on the market, not in US and in Europe or South America at the moment. The hematopoietic stem cells crossing the blood-brain barrier, and this is why they can stop the cognitive decline, and this is why we use it in MPS 1 if they are diagnosed very early, because then we can really stop the cognitive decline, and we have some transplanted patients that are going to the university. So actually it's really successful if you do it early. For MPS 2, it is also mentioned in some cases, and some countries are doing that, but unfortunately I think due to the older age when they are diagnosed, we don't have the success that we see in MPS 1. Would macrocephaly be accompanied with wide AF? Actually, this is intraventricular spaces probably, and the macrocephaly is sometimes indeed combined with an hydrocephalus. Sometimes it is it's a real hydrocephalus, so that you really need a shunt system, but sometimes it's also the enlarged intraventricular spaces because of the atrophy of the brain that you have in the neuronopathic patients, so the patients with cognitive involvement. Until what age is ERT affected for MPS? Actually, it is, in my opinion, I would start all patients immediately when I diagnose them. But since it is not a healing treatment, what I usually do is I plan for 1 year. I discuss exactly what the parents and the patients can expect from treatment. Whenever there's irreversible organ damage, for sure we cannot return to normal, but what we can do is we can slow down the progression of the disease. So we know that the joint contractures need quite a long time until they improve. We know the heart needs quite a long time, but they improve over time. And this is a stabilization of the disease. So actually I would start each patient. There are some countries that have special programs, so they start treatment and they check after 6 and 12 months, and there must be some improvement seen, so in order to continue the treatment. And I think every patient has the right to start, unless the patient is severely affected, is bedridden, has a severest cognitive decline and cannot move anymore. I mean, then I would not start. But in all other cases, I would start the treatment, discuss what is our goal, and then to see what is going on with the patient on treatment and how he improves or not. Is there any renal tract involvement in MPS? No. Actually, this is the only organ that is really excluded from the multisystemic organ involvement in MPSs. I have 2 MPS 2 patients with some blood in urine since a long time, but we don't find a cause. But it is not typical, like in Fabry's disease. We have no renal involvement in these patients. Also, hematopoietic stem cell transplants are available in which countries and available since when? Hematopoietic stem cells cell transplantations are available in quite a lot of countries, in Europe for sure, in US, but also in Middle East. I know that a lot of MPS patients are transplanted, also in Brazil, for example, but probably much more countries that I don't know at the moment. It is available much longer than the ERTs. The ERTs are available. The first ERT for MPSs in 2003, it was MPS 1. But I have patients that are transplanted 23, 24 years ago, MPS 1 patients, and they're doing very well, beside the skeletal involvement that is not solved by the stem cell transplantation. How about Sanfilippo treatment? Have you found organomegaly in them? Yes, in some Sanfilippo patients we find hepatosplenomegaly. We find also sometimes some skeletal involvement in these patients, but at an older age. And about treatments, there are some treatments in clinical trial at the moment. For example, there's one study for MPS 3B, or there was a study for MPS 3B with the intrathecal ERT, so the enzyme given directly to the brain, or CSF. There are some gene therapies trials ongoing, and also one which is very promising in MPS 3A. In UK, there's This is a kind of ex vivo gene therapy. So the child is giving their own stem cells. These stem cells will be genetically transformed with the correct gene, and also a kind of speed up gene so that more enzyme is produced, and then these stem cells are retransplanted to the patient. And I enrolled one patient in that study in Manchester, and the child is doing very well. But there are a lot of new trials ongoing at the moment. So there are no further questions. Thank you so much also for your active participation and asking questions. The next week you will hear Professor Maurizio Scarpa on Spot the Science of MPS. I'm very happy that I was here with you today. Thank you very much. Have a nice evening. And whenever you have questions, I gave my email address, so you can also write me directly. Thank you very much.